Next, we're going to kind of make a shift to a little different approach to the whole thing. We're going to have Gentian Lluri, who's one of our esteemed graduates of the program, now on the faculty, going to talk to us about bench to bedside. Come on up.
Thank you, Dr. Child, and thank you to all of you for being here today. Actually, a lot of you have been traveling actually from all over the country, from the East Coast. Some of you probably have been awake since 4 in the morning, Todd. Excited about the conference. And I was asked by Jamil and Pam to volunteer to talk about research. And I was like, what? In 10 minutes, 15 minutes? So I'm going to spend the next 2 hours to go in detail. No, I'm just kidding. Some people are already living with drink tickets, running outside. No, but this is going to be really broad strokes of what it takes to do research in an adult congenital heart disease center. And I think you're going to see the same theme that we've seen throughout the day today. It is a truly multidisciplinary approach. This slide, unfortunately, hasn't changed yet. It's still none in terms of disclosures yet. But why do we do research? In medicine in general? Well, it is because of the research that has been done over for generations now, is that we don't practice medicine anymore like we practiced in the 15th century. And if you look at the research that has been done in cardiology in particular, it has been at the forefront of the advancing our knowledge and our ability to treat patients, cardiology in general. And if you look at this graphs here, the mortality, cardiac mortality has significantly decreased and continues to decrease over decades compared to some of the other conditions. It's a very, cardiovascular disease is very, very common, so there have been literally hundreds of trials, thousands of trials with millions of patients over years that have allowed us to gain this knowledge in cardiology. However, patients with congenital heart disease is a completely different story. First of all, it's not that many of them, and the conditions that they have are completely different quite often. And for some cases where you'd think that would be similarities, for example, I have an example there where patients with systemic right ventricle, if they are in heart failure, a lot of medications that we use for heart failure in somebody who doesn't have congenital heart disease, in these patients, those medications don't work. So what do you do? In one way or the other, you've seen these numbers in terms of patients, the number of adult patients with congenital heart disease over years. And if anything, the number of the patients who survive to 18 years old nowadays is probably even higher than what you see on in that slide, making the point that there is an ever-increasing number of patients and ever-increasing need of having evidence-based medicine in terms of being able to treat these patients. One thing that I did, actually, I went on PubMed and searched how many publications have been per year related to congenital heart disease. Actually, it's much easier than it sounds. I didn't go and count it. If you ask the PubMed, it will give you an Excel sheet where per year it will tell you the number of publications that have been pertinent to congenital heart disease. And it goes even beyond, even further back than 1942. But anything before that and up to that time, it's pretty much one publication per year. So really, there was nothing before. And all those publications are pretty much case reports, descriptions of, this patient was seen with this condition and so forth. And nothing really for the next 30, 40 years. And it was only in the late 80s, early 90s, where you see this rapid increase of publications with congenital heart disease. And I just want to kind of take a minute here, and if you recall, Dr. Lax said, need for creativity. Dr. Rimson said, rewrite the history. And in all the talks that we've seen today, Dr. Leavis, Dr. Abulhosen, and so forth, pretty much the common theme is challenge the status quo. Try to come up with something that is better. Yes, we have the technology, but can we make it better? And this is exactly the reason why it's such an evolving field in terms of the patients and the research with adult patients with congenital heart disease. What are some of the specific challenges? Well, there's many of them. First of all, there is a very diverse group, this is a very diverse group of patients where we cannot generalize and treat all the same way. Conditions are different: atrial septal defect, ventricular septal defect, tetralogy, single ventricle with fountain physiology, et cetera, et cetera, et cetera. So we cannot really do like a project and include all these patients. It has to be tailored, it has to be specific to the condition or the clinical outcomes. Is it the heart failure that we're looking at? Is it the arrhythmias that we're looking at? And on a side note, I know we're getting to the end of the day today. After my talk, Dr. Moore, he's going to talk a little bit about the arrhythmias as well, and they are doing some of the stuff that literally nobody else in the world is doing. Is it the valve dysfunction or the non-cardiac outcomes? Pam, Linda, David talked a little bit about some of the psychosocial issues and so forth. Dr. Vanik from the hepatology and so forth, pulmonary, Dr. Sagar. So really, it's not just the heart that needs to be addressed in these patients. It's a multi-organ, multidisciplinary approach and so forth. Mary talked about the pregnancy outcomes and so forth. And then, in terms of we have a really developed a very well-oiled machine when it comes to the research. We have the research team, Rachel, Greg, and Johnny here, who really are on top of getting the paperwork process. That's always the first thing to do. We come up with the ideas, whether it's in clinics, in patients, over a cup of coffee. Let's think about it, and let's just do it. And then we get the paperwork done. And then it's the hard part, and obviously identify the necessary patients, which sometimes it just takes asking Pam, and she literally knows all the patients. She'll just give you you better be ready with a pen and a piece of paper and writing down names. And some of the projects are specific to, again, patients with fountain physiology, atrial septal defect, and so forth. We have probably dozens of projects, ongoing projects right now in our center that affect one way or the other almost all of our patients. And definitely the purpose of this talk is not to go of all of those projects. However, at the end, I'll show a couple of slides with specific data, unpublished data yet, that are very, very interesting. An inherent problem with the adult congenital heart disease is that it's a relative small number of patients. Again, compared to cardiology in general, where a lot of trials include thousands of patients, we don't have that many patients. And again, it is a very diverse group of patients. So how do you at least try to solve, at least partially, that problem? And one is trying to collaborate at the national level with other centers throughout the country. And this is one of the purposes of the ARC, which is the Alliance for Adult Research in Congenital Cardiology, where Dr. Abulhosen is one of the founding members since 2006. And the idea is not only to collaborate, so if we're doing something and our colleagues at University of Washington are doing the same thing without knowing, and then they also are doing something that the people in Boston are doing something, so we can all coordinate and share our data and hopefully increase the number of patients and the power of our analysis so we can come up with meaningful results. And hopefully, this is like a dream, but hopefully at the international level, there is, maybe this is not a problem that is in the United States or in Europe for that matter, it's a worldwide problem. So can we have that level of collaboration at the international level where obviously the technology in a lot of places is not what we have, but nevertheless, the need for care for evidence-based medicine is it's critical. Going back to like the multidisciplinary approach, it is literally when we talk about research, one of the things that comes in mind, well, somebody with a pipette, kind of doing their thing in the lab, or somebody in front of the computer trying to analyze, but literally it's this, where our team, we identify a project and we pretty much talk to every of these specialties that you have here to come up with and And on a side note, I'm going to show some data of one of our ongoing projects, and part of the project is to go to the operating room and obtain some tissue of the aortic valve. And after our Wednesday conference, I approached Dr. Lax. Like I was, so early in the career and talking to a legend, and I was probably mumbling, and he was kind of giving me that facial expression, not giving any, anything. Like I was like, okay. And then he listens, and he was like, fantastic, I love it. And then, do you want some of the aorta? Do you want some of this? I'm like, whoa. And he was like, and here's my cell number. Literally, I'm not making this up. So it makes it so easy to get work done when you have people not only who are willing to collaborate, but also excited about the project. And that goes for all the specialties. I have on speed dial, Dr. Ranella and Dr. Finn from radiology. I have Dr. Fishbein from pathology. So all their cell numbers, I have them just in case we need to have some conversation that can't wait. Usually it's not done by email. I hate that, just like email and waiting for the reply. It's face-to-face over a cup of coffee, and sometimes that's when the best ideas come. It takes obviously our pediatric cardiology colleagues, as I mentioned, non-cardiac specialties, GI pathology, pulmonary, obstetrics, adult cardiology certainly, EP. All of our patients pretty much have EP issues. Critical part of our research is our NPs, Linda and Pam, Jennifer, David, residents, fellows, medical students. We have a significant number of our trainees who are actively involved in one project or the other, which leads to publication and the advancement of the medical knowledge. Interventional radiology, Dr. Moriarty showed some of amazing work that they're doing as well. And with this, I just want to go to a couple of examples. One is bicuspid aortic valve. It's arguably the most common condition in congenital heart disease. Not a complex one, but nevertheless, calcification of the aortic valve leads to early stenosis and need for aortic valve replacement. Again, 1% to 2% of the general population. Now, some of these MRI images, definitely not as cool as the images that Dr. Finn just showed, but we came up with the idea that since all of our adult congenital patients have, as a matter of standard practice, have a cardiac MRI when every 3 to 5 years when we see them in clinic, our thought is there anything that we can get from the MRI to better prognosticate the outcome or the need for aortic valve replacement of these patients? And there is the concept of late gadolinium enhancement. If you see here, this is on a normal MRI. This is a left ventricle. This is a myocardium, black. And here with an arrow, it's this white part here. It's basically enhancement, gadolinium enhancement in the myocardium, which is suggestive of fibrosis. Basically, scar tissue, potentially calcification. And what we found, we looked at all our patients who had MRIs with or without gadolinium enhancement. And what we found is, again, this is unpublished data. We need to verify this with a larger group of patients. But if you look at the graph here on top, the patients who have late gadolinium enhancement are 10 times more likely to need a valve surgery within a year. They are 55% needing valve surgery as opposed to about 5% of patients who don't. And if you do a Kaplan-Meier curve on the bottom, at 5 years, almost all of these patients who've had gadolinium enhancement present in the MRI will need surgery. And this is kind of going back to the ARC idea, the nationwide collaboration, trying to collaborate with other investigators in these other institutions to see if this holds true down the road in a larger group of patients. But it's definitely very exciting early results. Now, same with the same group of patients. As I said, after all the paperwork was done and we talked to the surgeons and everything is all set, I went to the operating room, and there was a few patients actually, over a span of time, who needed aortic valve surgery. So with the help of the surgeon and our pathology colleagues, I'm able to collect a small piece of the aortic valve. And what we do, part of the aortic valve, there is this called valve interstitial cells or valve fibroblasts. And the thought is that it's already known that part of the calcification process in these patients is that these fibroblasts become bone-like cells. They calcify. So, okay, can we take these cells and put them in a dish? So here is cells, the fibroblasts from human valve, aortic valve, in a growth media. They grow, they are fibroblasts, they're happy cells. And then what we also have the ability by changing the chemistry of the media, of the media that we feed them with, to induce and make them bone-like cells, to calcify. That's what you see in red, in B in the middle. So basically we're kind of mimicking what's happening in a human, in a person with a bicuspid aortic valve. We're trying to mimic that, replicate them in a dish, where we see like, okay, a lot of calcium, which is shown in red. And you see at the C now. At C is the same type of cells as in B with calcification media, so these cells would calcify. The only difference we've had it some kind of chemical inhibitor that we're studying. Completely gone. So this is one of the exciting new findings, along with, again, a lot of other projects, but taking this to the next level, doing animal studies, and potentially in the future human trials where we can come up with new therapeutic strategies that helps not only the patients we see on a daily basis, but future generations here and in the world as well. And with this slide in mind, I want to thank you all for coming. Thank you.